We've had a very comprehensive overview of the information and clinical considerations with regard to the use of psychotherapeutic medications amongst children. From a public policy perspective, why does this receive so much attention? One of the things that Dr. Carell mentioned was relatively little information, although that's changed over time. Until recently, much of the information that we had available to guide our practice of using psychotherapeutic medications amongst children derived from adults. But children, as we know, are not just little adults. From a vulnerability perspective, there are a number of reasons why we need to think of children differently. They're rapidly growing brains, and that makes a huge difference. There's a certain vulnerability to things that might happen in this phase that might significantly exaggerate the impact of that effect. They're dependent on others. When I go to see my doctor and my doctor says to me, this is the problem you have, and this is what we can do to help you with this problem. These are the pros and cons. These are the possible side effects. These are your choices. I get to have that conversation with my doctor about what treatment I might choose. But a child is completely dependent on a third party, his or her parents, or someone else that represents the child. And so that is an issue that we need to be cognizant of. As I mentioned earlier, it's a period of rapid development, rapid growth. And as Dr. Carell showed us, we cannot assume that the treatments are as effective or as risky or have the same profile of benefit and risk in children as they do in adults. There are differences. Children, medications, antidepressants, for example. One of the surprising things, we all talk about the increased risk of suicide or suicidality in the context of antidepressant treatment in children. But perhaps the more vexing problem with regard to antidepressant use in children is they appear to be less effective than they are in adults. It's not so much an increased side effect vulnerability as much as a reduced efficacy relatively speaking to adults. That's a bigger concern. So these medications are not as similarly effective in children as in adults. There are differences. Dr. Carell noted the significant differences in side effect vulnerability. They respond differently to treatment, different vulnerability to side effects, and this is in the context of their higher vulnerability and the fact that they're rapidly growing. Now, fortunately, over the last 6 to 8 years, things have changed with regards to the amount of data. And Dr. Carell noted the approximately 4,000 to 5,000 children that have provided significantly additional information in the context of randomized controlled studies with regards to different classes of psychotherapeutic medications. But prior to that, information was somewhat limited. So why are policymakers paying a lot of attention to this particular topic? Well, firstly, we're always sensitive and more concerned about what happens to our children. We feel we have a particular responsibility towards them because they can't take care of themselves as society, and we collectively have to take care of our children. We pay more attention to what happens to them. And in the context of psychotherapeutic medication use, how well do we understand psychiatric illness amongst children? When do what disorders begin? And concepts are changing, rapidly evolving. And in this context, there's been a several-fold increase in the use of different classes of psychotherapeutic medications. Now, as Dr. Carell noted, is that because we are overprescribing now, or we were underprescribing before? Are we diagnosing differently? Are we diagnosing better now? Or are we diagnosing more broadly, overly diagnosing now? Now, as a policymaker, we don't have answers to these questions. As experts, we struggle with these issues. as Dr. Carell noted. The other issue in terms of psychotherapeutic medication use, the utilization has been increasing. And if you think about their use relative to other treatment modalities, different kinds of therapies, etc., that's changing. So there's less use, less access to different kinds of psychological therapies, social treatments that might otherwise be effective as well for the treatment of a range of conditions. And the other thing that we sometimes forget about, in the past, policymakers said, you know, you've got doctors who, practitioners, clinicians, who are the experts. They decide, you know, what works, what doesn't work. And we trust it to them to do whatever needs to be done. Our basic job is to provide them with the resources to do what they think is right. Now, the practice of medicine has really changed over the last 2 to 3 decades. Prior to that, much of the practice of medicine was experience-based. That is, I trained as a physician, then I trained as in my particular specialty, and then I practiced it. And by the fact that I had a certain amount of experience, that was enough in terms, then I did what I thought was right. And that was sufficient evidence. Over the past 2 to 3 decades, there's been an increased emphasis on what is called evidence-based medicine, not experience-based medicine. Show me the data. I want to see, you think it works, and you might be, you know better than I do, but where are the data to tell me that it really works, that this treatment is better than that treatment? Ultimately, choices have to be made between the parent, the treater, in conjunction with the child about what's best for that child. But this happens in the context of evidence that must guide practice. And Dr. Carell did an outstanding, absolutely masterful job of reviewing the vast amounts of evidence, if you will, that needs to be considered as we look at this practice. But this increased emphasis on evidence-based medicine is relevant from a practitioner perspective as well, because that's what policymakers ask. So what's the data? What are the data that tell me that this is a better choice? I'm paying for it. I'm responsible for the children, for the welfare of the children in a broad sense. That's a particular responsibility. I want to look at data. If you can persuade me with data, I'm willing to be persuaded. And that's where policymakers are at. Now, before we get to this, it's important to keep in mind that ultimately everything is a benefit to risk consideration. Should a particular treatment be utilized? Should a particular medicine be utilized? Or should a medicine not be utilized? It's always a matter of benefit to risk. Are the benefits likely benefits, and you cannot predict because there's so much variation in how children or any patient responds to treatment. Are the likely benefits significantly outweighing the possible risks? And as you have these considerations with regard to medication, which medication, medication or no medication, medication or therapy, it's really important to consider what it is that you're treating to begin with. The conditions that we're talking about are not benign conditions. So when you think about no treatment, it's important to think about the impact of no treatment. This is a terribly important age with children. We talked about the rapid growth. Well, if the illness or whatever it is that they're struggling with is not effectively addressed, what effect does that have on their development, on their learning, on their ability to adapt, learn adaptive skills, if you will? That's a very important consideration. And so ultimately, benefit to risk consideration, and the idea is to maximize the likelihood of benefit and minimize possible risk in the choices that one makes, and then assess what's happening to the child as you go along. One of the things that Dr. Carell alluded to, but in the context of the number of topics